Thank you for viewing our voiceover PowerPoint. We will be presenting information regarding intraoperative awareness with recall under general anesthesia, which will now be referred to as AWR throughout the presentation. While some content may be review, our intent is to attempt to improve knowledge and practice regarding assessment, evaluation, and treatment of AWR. Here is a list of some common abbreviations used throughout the presentation for your reference. Our objectives are to discuss the current gap between knowledge of AWR and practice by anesthesia practitioners, identify areas where practice can change to close the gap, present tools available to assess for AWR, describe appropriate and effective time intervals for evaluation of AWR, and present resources available to assist in treatment of AWR sequelae. Through an extensive literature review, we identified a gap exists between anesthesia practitioners' perceived knowledge of AWR and their practice. Particularly, there is a lack of assessment, evaluation, and treatment of AWR by anesthesia practitioners. While most anesthesia practitioners are familiar with AWR as a phenomena, research has shown it is inadequately assessed, evaluated, and treated in patients receiving general anesthesia. For the purpose of this educational program, anytime AWR is referred to, it's only inclusive of surgical cases in the operating room under general anesthesia and does not include sedation, monitored anesthesia cases, or the time before induction or emergence of general anesthesia, when awareness is acceptable for patients to return to a state of consciousness. The Joint Commission defines AWR as an unintended intraoperative awareness occurring under general anesthesia. The patient becomes cognizant of some or all events during surgery or a procedure and has direct recall of those events. Because of the unique routine use of neuromuscular blocking agents, the patient is often unable to communicate with the surgical team if this occurs. The AANA defines AWR as explicit recall of sensory perceptions that occur during general anesthesia, with specific reference to explicit recall as a determining factor for anesthesia awareness. AWR was first identified in 1937 by Gibbs, and Lennox, and then in 1960, the incidence of AWR was found to be 0.8% to 1.2%. However, no sequelae was appreciated. In 1990, acceptance of AWR sequelae and EEG monitoring technology became available. In 2004, the Joint Commission issued a sentinel event warning in response to surfacing research, citing that AWR incidence was 0.1% to 0.9% of all patients receiving general anesthesia. Although the AANA and the ASA published guidelines in 2000 to prevent AWR, the alert prompted the groups to revisit the subject. In 2005, the AANA, the ASA, and the AAAA published a joint brochure educating patients on AWR. These professional organizations continue to revise their recommendations and resources for patients and practitioners regarding AWR, with continued stress on the importance and reality of this anesthetic complication. When research conducted regarding anesthesia practitioners' perceived knowledge, familiarity, and comfort in assessment, evaluation, and treatment of AWR, no studies or literature was found. In practice, no discussions of potential for awareness has been witnessed. Anesthetists describe AWR as being a complication they wish to avoid, only second to death. Most practitioners assume that through questioning, a platform of suggestion is created. One way that may assist in preventing suggestion while discussing risk is stating, while falling asleep before surgery and or waking up after surgery, you may remember hearing me say things like take a deep breath or squeeze my hand. Know that your surgery is done. However, awareness during anesthesia is a risk, though it is very unlikely, and we have monitors to assess for it. 35% of patients who say they have experienced AWR never told their anesthetist because they were frightened and did not want to be deemed as crazy. Unfortunately, this mentality has seemed to be unchanged 12 years later, with limited assessment and extreme lack of knowledge related to the evaluation and treatment. Multiple researchers have stated AWR is generally underestimated. He attributes this to several factors. Some anesthetists aren't concerned about awareness because it's never happened to them before, and he responds to this by saying, "It's never happened to you because you haven't looked for it." He has identified where practice can change to close this gap between knowledge and practice are assessment, evaluation, and treatment. Who is at highest risk? Patients with an ASA of 3 and 4, emergencies, multiple trauma, cardiac, obstetrics, pediatrics, and women. Two most used methods of monitoring are bispectral index monitoring, known as BIS, and end-tidal anesthetic concentration, referred to as ETAC, monitoring of volatile gases. These are widely accepted and utilized. While those methods are used in the operating room, an available tool to assess post-operatively is the Bryce questionnaire, which consists of a series of questions. Based on the answers to the Bryce questionnaire, it is identified if awareness occurred during general anesthesia.
The BIS is a monitor that assesses depth of anesthesia based on EEG analysis of burst suppression, spectral power of the beta bandwidth, and bispectral coherence. According to Ekman et al., the incidence of AWR in cases where the BIS was used was 0.04% compared with 0.18% in a historical group of 7,826 patients from a previous study of awareness in which no cerebral function monitoring was used. In the Be Aware trial, BIS guided anesthesia was found to reduce the risk of awareness by 82%. BIS monitors cost $1,000 or less and can be single-use sensor strips can be purchased for $13. These costs would seem insignificant when compared to the benefit of preventing AWR. When considering cost of prevention of AWR, if the technology is available, why not use it? Consider having the technology available, opting not to use it, and then having a patient who experiences AWR. ETAC monitoring is a measure of expiratory levels of anesthetic gas to help assess the level of anesthesia based on the percentage of gas exhaled. ETAC values are compared to the associated max of specific gases, for example, 2% of sevoflurane. ETAC monitoring and alarm limits allow anesthesia practitioners to determine if the patient is receiving a gas concentration that is associated with non-awareness. One study reported AWR to be as low as 0.07% when ETAC was used. While those methods are used in the operating room, an available tool to assess postoperatively is the Bryce questionnaire, which consists of a series of questions. The Bryce questionnaire is a validated tool used to structure a postoperative AWR assessment. The AANA and ASA recommend the use of the Bryce when interviewing patients about AWR postoperatively. The Bryce questionnaire includes the following questions. 1. What was the last thing you remember before going to sleep? 2. What was the first thing you remember after waking up? 3. Do you remember anything between going to sleep and waking up? 4. Did you dream during your procedure? And 5. What was the worst thing about your operation? Based on the answers to the Bryce questionnaire, it is identified if awareness occurred during general anesthesia. Anesthesia practitioners should be aware of the onset of psychological symptoms vary widely, anywhere from 7 to 243 days after surgery, with a median being from 4.5 to 5.6 years. Multiple randomized control trials have shown AWR occurs in 1 in 1,000 or 0.1% and up to 0.9% of all adults undergoing anesthesia. One hypothesis for the variation in results is due to the times postoperatively at which a patient is interviewed about AWR. Bryce questionnaires were developed to be used to interview patients immediately postoperatively and 1 to 2 additional times after the operation. Sandine et al. Interviewed patients in the post-anesthesia care unit or PACU 1 to 3 days postoperatively and 7 to 14 days after surgery. They reported an incidence of 19 out of 11,785 patients, or 0.16% in a prospective study of AWR. Sable et al. Interviewed patients in the PACU and 1 to 2 weeks postoperatively and corroborated findings in their prospective multi-center study in the United States, showing an incidence of 25 out of 19,575 patients, or 0.13%. In 2008, Arando and colleagues conducted a prospective observational study interviewing patients in the PACU and at 7 and 30 days postoperatively. They found AWR incidence was 39 in 3,921 patients, or 1%, and that incidence decreased to 0.8% when high-risk patients were excluded. Pandit cited the outlying study of AWR, conducted by Pollard in 2007, that showed AWR incidence occurring in only 1 in 14,500, or 0.007%. However, these studies were limited to interviewing patients at 48 hours postoperatively, possibly missing 1/3 of AWR reports. AWR sequelae includes nightmares, anxiety, depression, PTSD, avoidance of future surgical and medical interventions. PTSD develops following traumatic events and experiences, possibly permanently disabling the victims. PTSD is characterized by re-experiencing, avoiding, and psychological hyperarousal. PTSD has been noted to correlate with poor health choices and physical health symptoms. Prevalent sequelae include sleep disturbances, irritable bowel syndrome, chronic pain, multiple cancers, as well as negative health behaviors such as smoking, substance abuse, and poor eating habits. PTSD has a significant incidence in patients who experience AWR and can have long-term health consequences. Therefore, recognition, acknowledgement, and treatment are imperative. When this devastating event occurs, as anesthesia practitioners, it is important to be aware of resources available. In a majority of cases, patients are looking for an understanding and acknowledgement that what they recall did occur and that they are not crazy. As a provider, this can be very, very devastating to admit and deal with on a professional level as well. Resources and helpful tools are available to deal with recovery and acknowledgement of these events for the patient and the practitioner. 1 year after the Joint Commission deemed AWR a sentinel event, the AANA published a brochure, Patient Awareness Under General Anesthesia. What is it? This brochure was then revised in 2009 with a groundbreaking collaboration of the AAAA, AAC, ASA, and AANA because substantial new data and understandings in the area of patient awareness had arisen since its publication. This brochure is a tool to help us start a discussion with a patient about the possibility of AWR. It also provides information and resources needed to seek help and provide a safe forum to express experiences in the event that AWR occurs. A registry available is titled Anesthesia Awareness Registry, and it's a community of patients who have experienced AWR and offers support for those who have experienced it. The second victim, the anesthesia practitioner, may also suffer sequelae when their patient experiences AWR. Practitioners have available institutional specific employee assistance programs, peer debriefing, and professional organizations support from the AANA, ASA, and AAAA. In addition to physical and psychological sequelae, practitioners may face litigation. Litigation related to AWR can range from $18,000 to $300,000. When AWR is not treated and PTSD occurs, it is considered a severe disability and may face increased monetary claims. This does not include the patient's emotional cost. However, if the risk is communicated preoperatively, patients are less likely to explore litigation following AWR. Now you may proceed to the post survey. If you have any questions or concerns after completing the post survey, please feel free to email kellylannard@gmail.com or dulcieshippa@msn.com. Thank you for participating in this survey.